Hello students, listen to the lecture on the topic of ontogenesis of the female reproductive system and regulation of the menstrual cycle. Ontogenesis is the origination and development of an organism, both physical and psychological, usually from the time of fertilization of the egg to adult. It is customary to distinguish several periods of life. Intrauterine, which is divided to embryonic and fetal. Newborn period, it's the first 28 days of life. Infancy, up to 1 year of life. Childhood, up to 8 or 9 years. Puberty, from 8 or 9 years till 18. Reproductive period, which is start at 18 till 45. Premenopause, which is start between 45 and 47 to 50 and 53. Menopause, it's the first year after the last menstrual period, and postmenopause. In the first stage of gonadal development, it is impossible to distinguish between the male and female gonad. Thus it's known as the indifferent stage. The genetic sex of an embryo is determined by the sex chromosome, X or Y, carried by the sperm that fertilize the oocyte. In a male embryo, the Y chromosome contains the SRY gene, which stimulates the development of the primitive sex cords to form testes. In a female embryo, the X-sex chromosome are present. As there is no Y chromosome, there is no SRY gene to influence development. Without it, the primitive sex cords degenerate and do not form the testes. Gonads become structurally male or female by the 7th week of development, and external genitalia become differentiated by the 12th week. Take a look to this picture. The Y chromosome contains a gene called SRY, or sex-determining region on Y. The ovary-determining gene is VNT4. When this gene is present and SRY is absent, the embryo develops female characteristics. Now you may see on the left side, SRY gene absent means female formation, and on the right side, SRY gene present means male formation. The knowledge of embryology and anatomy of the female genital system is helpful in understanding both normal anatomy and the congenital anomalies that occur. In the first weeks of urogenital development, all embryos have 2 pairs of ducts, both ending at the cloaca. These are the mesonephric or Wolffian ducts and perimesonephric or Müllerian ducts. Starting from the 4th week of development, the intermediate mesoderm forms urogenital ridges along the posterior wall of the body. As the name suggests, those ridges help shape the urinary and reproductive systems. Professor Johann Peter Mahler, in the beginning of 19th century, was the first to describe the female genital duct that develops as the uterus and vagina. In both male and female embryos, two pairs of ducts develop, the mesonephric or Wolffian and paramesonephric or Mullerian ducts. As with the gonad, those ducts pass through an indifferent stage in which both pairs of ducts are present in both the male and the female embryo. In the presence of testosterone produced by Leydig cells, the mesonephric ducts develop to form the primary male genital ducts. In the female, there are no Leydig cells to produce testosterone. In the absence of this hormone, the mesonephric ducts degenerate. The perimesonephric ducts persist to form major parts of the female reproductive tract, fallopian tubes, uterus, and upper portion of the vagina. Perimesonephric ducts begin as invaginations of the epithelium covering the urogenital ridges. The cranial ends of each duct open into the body cavity. The upper end of the Mullerian duct is open. The lower end opens into the cloaca. The perimesonephric ducts degenerate in the presence of anti-Mullerian hormone produced by Sertoli cells in the testes. The absence of anti-Mullerian hormone allows for development of the perimesonephric ducts. The ducts grow caudally until the two caudal ends contact the posterior wall of the urogenital sinus. The lower ends of the perimesonephric ducts fuse to form the upper portion of the vagina, cervix, and uterus. The cranial portion of each duct remains separated and forms the fallopian tube on each side. Perimesonephric ducts can be described as having three parts. Cranial becomes the fallopian tubes. Horizontal becomes the fallopian tubes, and caudal fuse to form the uterus, cervix, and upper 1/3 of the vagina. You may see the uterus and vagina are fused parts, but uterine tube are non-fused parts. The ovary is temporarily found cranial to the uterine tube on the posterior side of the regressing mesonephric body, but moves to a position posterior to the uterine tube. The uterine tubes, which were the cranial parts of the perimesonephric ducts, are initially vertical. During development of the uterus, they move toward the interior of the abdominal cavity and become horizontal. The development of reproductive organs begins at an early stage in the embryo. The ovaries, fallopian tubes, uterus, and upper portion of the vagina are derived from the intermediate mesoderm, while the external genitalia develop from genital swellings in the pelvic region. Both types of gonads begin development as gonadal or genital ridges that forms during the 5th week of gestation from the urogenital ridges. During the 5th week of pregnancy, a female fetus's ovary contains about 500 to 1,300 primordial germ cells. Peripartum, each germ cell is regressed to form a primordial follicle containing an oocyte and a single layer of nourishing granulosa cells. By approximately 16 weeks of gestation, cortical cords in the ovary organize into primordial follicles. Two regions can be distinguished in the urogenital sinus: the urinary or cranial region, which describes the urinary system, and genital or caudal region. Differentiation of the genital portion of the urogenital sinus in the female follows that of the urogenital excretory system and begins in month 3, paralleling the formation of the vagina and the external genital organs. Differentiation of the external genitalia takes place during month 3. The genital tubercle elongates only slightly and forms the clitoris. The urogenital sinus remains open with urethra opening anteriorly and the vagina posteriorly within the interior of the vestibular portion of the sinus. The pelvic portion of the urogenital sinus becomes less deep, bringing to the surface the urethral orifice and the hymen, the place where the malar tubercle was, the hymen formated. Estrogens in the female embryo are responsible for external genitalia development. In the presence of estrogens and the absence of androgens, external genitalia are feminized. At week 4, the anterior end of the cloacal membrane retracts from the base of the umbilicum cord, permitting formation of the anterior body wall below the umbilicus, and the paired primordia of the genital tubercle come together in the midline from the genital tubercle. The cloacal fold, which surrounds the cloacal membrane, further prolongs the genital tubercle, and about this time new swellings appear, the genital swellings on the other side of the cloacal folds, and surround the genital tubercle and the cloacal folds. Thus form the urogenital sinus develop vestibula vagina and urethra feminina. The genital tubercle elongates only slightly and forms the clitoris. The urogenital sinus remains open with the urethra opening anteriorly and the vagina posteriorly within the interior of the vestibular portion of the sinus. The vestibula is bordered laterally by genital folds, which become the labia minor. The genital swellings largely remain unfused and forms the labia major. Thus, urogenital sinus form hymen and vaginal vestibula. Genital tubercle forms clitoris. Genital folds pulp of the vestibula and labia minor. Genital swellings form labia major. At week 7, the cloacal membrane is divided into the urogenital membrane anteriorly and the anal membrane posteriorly, separated by the perineal body or perineum. On this image, you may see separation of the anus from the urogenital sinus. By 7 weeks of embryo development, the indifferent stage of gonade formation ends. At 20 weeks of gestation, primordial follicles forms in the ovaries. By the time of birth, the ovaries are morphologically formed. The fallopian tubes, uterus, and the upper third of the vagina originate from the paramesonephral duct. The uterus and tubes arise from the Mullerian duct, which first appear near the upper pole of the urogenital ridge. 2 Mullerian ducts fuse to form a single canal. The upper ends of the Mullerian duct produce the fallopian tubes, and the fused part give rise to the uterus. Now let's talk about girls' development stages. Newborn, first 28 days of life. Infancy, up to 1 year of life. Childhood, up to 8 years. Prepubertal, from 8 till 12 or 13 years. Pubertal, which starts between 12 and 13 till 16 or 70 years. In newborn period, signs of estrogenic effects are found in the genitals and mammary glands. Even in endometrium, proliferative and even secretory transformations are determined. On this image, you may see external genital organs in beginning life stages. On the left side, 5 months female fetus, and on the right side, a newborn girl. On this image, you may see external genitalia of the prepubertal child. On this table, you may see changes of the vagina in prepuberty and puberty. For example, vagina pH is alkaline in prepuberty and starts to be acidic in puberty, or vagina discharge, which is absent in prepuberty and present in puberty. Also vagina length, which is short in prepuberty, 5 cm, and 11 to 12 in puberty. In childhood period, the external genitals and mammary glands are formed, but not developed. About internal genitalia, the uterus is small, the neck in length and thickness exceeds the size of the uterus body. Fallopian tubes are thin, the vagina is narrow and short. Prepuberty is an endocrine process that involves the physical, emotional, and sexual transition from childhood to adulthood. It's a period of gradual development of secondary sexual characters. The process of secondary sexual maturation requires approximately 4 years. The end of this phase coincides with the onset of menarche. There are profound biological, morphological, and psychological changes that lead to full sexual maturity and eventually fertility. 5 important physical changes are evident during puberty. Those are breast, pubic and axillary hair growth, growth in height, and menstruation. Most of the changes occur gradually, but only the menarche can be dated. A series of endocrine events initiate the onset of secondary sexual maturation. The hypothalamic pituitary gonadal axis begins to function during fetal life and remains active during the first few weeks following birth, after which time the axis becomes questioned secondary to enhance negative feedback of estrogen. The hypothalamic pituitary gonadal axis again becomes active during puberty, triggering the production of gonadotropin-releasing hormone. The gonadotropins control production of sex steroids from the ovary, and higher levels cause the physical changes of puberty. The reproductive period starts at 18 and lasts till 45 years. This period considered optimal for conception. After 45, the reproductive system fades away. Menopause is the permanent cessation of menses after cessation of estrogen production. Perimenopause is the period before menopause, the transition from the reproductive to the non-reproductive years. The time period during which the changes of menopause occur is called the climacteric. The time period before menopause is called perimenopause. Perimenopause symptoms occur for 4 years on average. During this time, the hormones estrogen and progesterone are in flux. Level of these hormones are fluctuate from month to month. In premenopausal period, gonadotropin levels starting to rise. During this time, there is evidence for a reduced number of gonadotropin receptors in perimenopausal ovaries, and inhibin production from granulosa cells falls, leading to reduced inhibin. FSH level rise 10 to 20-fold. LH rise only 3-fold due to its shorter half-life. Hot flashes are thought to arise due to loss of estrogenic-induced opioid activity in the hypothalamus, leading to thermal dysregulation. Other typical immediate menopausal symptoms include insomnia, anxiety, irritability, memory loss, tiredness, and poor concentration. The menopause transition can also be associated with significant reduction in sexuality and libido. This not only because of decreased vaginal lubrication leading to dyspareunia, but also due to the reduction of androgens. Estrogen deficiency leads to rapid loss of collagen, which is contribute to the generalized atrophy that occurs after the menopause. The vagina epithelium, cervix, endocervix, endometrium, myometrium, and uroepithelium are estrogen-dependent tissue. With decreasing estrogen production, those tissues become atrophic, resulting in various symptoms. The vaginal epithelium becomes thin, and cervical secretion diminish. Women experience vaginal dryness while attempting or having sexual intercourse, leading to diminished sexual enjoyment and dyspareunia. Atrophic vaginitis also may present with itching and burning. This thin epithelium is also more susceptible to becoming infected by local flora. The endometrium also becomes atrophic, sometimes resulting in postmenopausal spotting. The paravaginal tissue that support the bladder and rectum become atrophic. estrogen level drops due to reduction in follicle number and qualitative effect on granulosa cell aging. There is a permanent cessation of progesterone production. Collagen loss contributes to the generalized atrophy that occurs after the menopause. In the genital tract, this is manifested by the dyspareunia and vaginal bleeding from the fragile atrophic skin. In the lower urinary tract, atrophy of the urethral epithelium occurs with decreased sensitivity of urethral smooth muscle and decreased amount of collagen in periurethral collagen. All these result in dysuria, urgency, and frequency, commonly termed the urethral syndrome. Coincident with the change in reproductive cycle length and frequency, the hot flash is the first physical manifestation of decreasing ovarian function and is a symptom of vasomotor instability. The hot flash is the most common symptom of decreased estrogen production and is considered one of the hallmark signs of perimenopause. Now, let's talk about regulation of the menstrual cycle. Menstruation, or normal periodic uterine bleeding, under the influence of pituitary and ovarian hormones. This recurring process is established during puberty and continues until the years prior to menopause. Menarche usually occurs at age between 12 and 14. Regular ovulatory cycles are usually established by the third year after menarche and continue until the perimenopause. Therefore, between 15 and 45 years of age, a woman has approximately 30 years of ovulatory reproductive cycles. Its termination is an menopause and normally occur between 49 and 50. However, medical, some disease, radiation, or surgical intervention may cause artificial menopause at an early ages. Normally, menstruation is regular and painless. The reproductive cycle may be interrupted by conditions including pregnancy, lactation, illness, gynecological disorders, endocrine disorders, some exogenous factors such as hormone-based contraceptives, and various other medications. The first day of menstrual bleeding is considered day 1 of the menstrual cycle. Normal menstruation lasts 3 to 7 days, during which women lose approximately 50 to 90 milliliters of blood. The duration of an adult menstrual cycle from the beginning of one menses to the beginning of the next menses averages approximately 28 days, with a range of 21 to 35 days. Uterus consists of 3 layers: epilae, serosa, middle layer, myometrium, and inner layer, endometrium. The uterine cavity is aligned with endometrium, which is composed of an overlying epithelium, invaginating glands, and a supportive vascular stroma. This layer is divided into functional layer, which is loaded with menses, and basalis layer, which is served to regenerate the functional layer following each menses. Hypothalamus, pituitary, ovarian axis refers to the complex interactions between the hypothalamus, pituitary, and ovaries that regulate the reproductive cycle. Those interactions are based on the interplay of the hormones released by those structures. Gonadotropin-releasing hormone, the gonadotropins, follicle-stimulating hormone or FSH, and LH, and the ovarian sex steroid hormones, estrogen and progesterone. Menstrual cycle comprises three distinct phases. The follicular phase begins with onset of menses and ends on the day of luteinizing hormone surge. Ovulation occurs within 30 to 36 hours of LH surge. The luteal phase begins on the day of LH surge and ends with the onset of menses. The follicular and luteal phases each last approximately 14 days in reproductive age women. The gonadotropin-releasing hormone is secreted in pulsatile fashion from the arcuate nucleus of the hypothalamus. Gonadotropin-releasing hormones reach the anterior pituitary through the hypothalamic pituitary portal vascular system. The pulsatile secretion of gonadotropin-releasing hormone stimulates and modulates pituitary gonadotropin secretion. The pituitary gonadotropins, FSH and LH, are glycoprotein hormones secreted by the anterior pituitary gland. FSH and LH are also secreted in pulsatile fashion in response to the pulsatile release of gonadotropin-releasing hormone. The rate of secretion of FSH and LH are determined largely by the level of ovarian steroid hormones, estrogen and progesterone, and as ovarian factors. At birth, the human ovary contains approximately 1 to 2 million primordial follicles. A large number of those inactive primordial follicles undergo a degenerative process known as atresia during childhood. Close to menarche, only 300,000 to 500,000 oocytes remain. The immature oocyte is encircled by a single layer of granulosa cells, followed by a thin basement membrane that separates the follicle from the surrounding ovarian stroma. Granulosa cells produce estrogens, including estrone and estradiol. During follicular development, FSH binds to FSH receptors on the granulosa cell, causing cellular proliferation and increasing binding of FSH and hence increased production of estradiol. Estradiol stimulates the proliferation of LH receptors on theca and granulosa cells, and LH stimulates the theca cells to produce androgens. Greater androgen production leads to increased estradiol production. Rising estrogen levels influence the pituitary gland through negative feedback and result in suppression of FSH and LH secretion. In the late follicular phase, peak estradiol concentration from the dominant follicle have positive feedback on the pituitary, which stimulates the mid-cycle surge of LH secretion that is necessary for ovulation. On the 8th and 9th day of the cycle, the estrogen level stops rising and LH and FSH levels begin to fluctuate. With ovulation, the dominant ovarian follicle releases its oocyte and transition to a progesterone-secreting ovarian cyst, the corpus luteum. The production of progesterone begins approximately 24 hours before ovulation and rises rapidly thereafter. Maximal progesterone production occurs 3 to 4 days after ovulation. The lifespan of the corpus luteum ends approximately 9 to 11 days after ovulation. On this image, you may see ultrasound visualization of ovarium. Just right in the middle, you may see major dominant follicle. On this image, you may see uterus. Just right in the middle, endometrium, which lengths depend on the day of the menstrual cycle. For example, just right in the middle of menstrual cycle, the normal length of endometrium should be approximately 1 centimeter. If conception doesn't occur, the corpus luteum undergoes involution and progesterone production sharply declines. This withdrawal of progesterone releases FSH from negative feedback. Those FSH levels begin to rise prior to menstruation and the initiation of new cycle. The corpus luteum measures approximately 2.5 centimeters in diameter, has a characteristic deep yellow color. After a few months, the corpus luteum becomes a white fibrous streak within the ovary, called the corpus albicans. At the end of the luteal phase, serum concentration of estradiol, progesterone, and LH reach their lowest levels. In response to low hormone levels, FSH begins to rise. In the late luteal phase, before onset of the menstruation. The endometrium undergoes histological changes during the menstrual cycle. During menstruation, the endometrium is expelled and only the basal layer remains. During the follicular phase, the rise in estrogen levels stimulates endometrium cell growth. The endometrial stroma thickness and the endometrial glands become elongate to form the proliferative endometrium. Each cycle generally passes through 4 phases: the menstrual phase, the proliferative phase, the ovulatory phase, and secretory phase. On this image, you may see the changes in ovarian follicles and in the uterine endometrium. Menstrual phase or menstruation refers to the shedding of the superficial layers of the endometrium with subsequent repair in preparation for regrowth from the basalis layer. Menstruation is initiated by a fall in circulating concentration of progesterone. After a menstrual period of 3 to 7 days, bleeding gradually diminishes. An interval between ovulation and menstruation normally is almost exactly 14 days. On this image, you may see endometrial stroma, which consists from functional and basal layer. New proliferative endometrium grows rapidly under the influence of estradiol, in synchrony with the growth and maturation of the oocyte and its follicle. A key element in growth of healthy endometrium is formation of new blood vessels, which seems to occur by elongation and expansion from pre-existing small vessels in the basalis. The proliferative phase consists of early phase, the middle proliferative phase, and late proliferative phase. On this image, you may see synchronized ovarian cycle and uterine cycle. You may see the changes in endometrium depending on the day of the menstrual cycle. During ovulation, the oocyte is expelled from the follicle, and the follicle is converted into the corpus luteum. The ovulatory phase occurs with ovulation on about the 14th day of 28-day cycle. The secretory phase technically begins with ovulation. The development of healthy secretory endometrium is essential for implantation and successful development of pregnancy. A menstrual cycle plays basic role in realizing future reproductive function. Thus why some menstrual abnormalities may lead problems with reproductive function. Thank you for your attention.